Dear viewers, we welcome all of you to our lecture on cervical nodal dissection. The surgery was first described by the American surgeon George Washington Crile in 1906. The procedure underwent significant modifications during the 1950s and 1960s and is now accepted surgical practice for a selected group of head and neck cancers. This is the classification of cervical lymph node into 6 levels according to the American Academy of Otolaryngology. As you can see, there are 6 levels of nodes. Levels 1, 2 and 5 are further subdivided into levels 1A, 1B, 2A, 2B, 5A and 5B respectively. Most texts describe 3 types of nodal dissections. Radical lymphadenectomy or radical neck dissection means removal of the interior jugular vein, the accessory nerve and the sternocleidomastoid muscle together with all macroscopic lymphatics on one side of the neck as a standard procedure. Modified radical dissections try to preserve any or all of the above 3 structures, and selective nodal dissections target the first and second tier nodal groups of a head and neck cancer. From our vast experience, we can say that one can preserve all these 3 structures in most cases and perform a macroscopically complete nodal dissection. However, if there is any evidence of macroscopic invasion of any of the above 3 structures, we do not hesitate to excise the involved part of the structure en bloc together with the lymphatics. So, in our view, there are only 2 types of block dissections. Comprehensive nodal dissection, which means a complete macroscopic nodal dissection, usually excluding level 6 unless there is clinical evidence of level 6 lymphadenopathy or in the case of thyroid or laryngeal cancer. The other type is selective nodal dissection. Now let's look at the malignancies for which a comprehensive or a selective nodal dissection may be recommended. First, confirm head and neck squamous cell carcinoma. Second, a squamous cell carcinoma of an unknown primary. Third, differentiated thyroid cancer and medullary thyroid cancer. Fourth, parotid carcinoma except possibly adenocarcinoma of the parotid gland. And finally, head and neck melanomas. A comprehensive nodal dissection is indicated in 2 instances. First, if there is histological or cytological evidence of metastasis in a single or multiple level nodes. Second is recurrent disease after primary surgery or radiotherapy. On the other hand, a selective nodal dissection is indicated in the presence of a resectable lesion in the head and neck region with high metastatic potential without clinical evidence of nodal metastasis. You can see the examples below. In this lecture, we will be talking about comprehensive nodal dissection. Since selective nodal dissection means removal of 1 or 2 levels from the 6 levels of nodes without clinical evidence of malignancy. The incision is important. Our preferred incision is shown in figure A, which minimizes the risk of flap necrosis in the edges. In this slide on the left, You can see how a thyroidectomy incision can be extended laterally to perform a selective lateral or even a comprehensive neck dissection. On the right, you can see the standard incision for an upper cervical nodal dissection for oral malignancies which have a high potential for occult metastasis. Remember, if you do not raise the flaps in the proper plane, flap necrosis is very likely to happen. This is what you see once you have raised the flaps. In this slide, number 1 shows the sternocleidomastoid muscle, number 2 the external jugular vein, number 3 the greater auricular nerve, and number 4 the anterior deep fascia containing the anterior jugular veins. In the standard radical dissection, the fascia along the anterior border of the sternocleidomastoid muscle is incised, and the sternocleidomastoid muscle is separated if there is any evidence of tumor attachment. In most cases, when doing comprehensive nodal dissection, we do not divide the muscle, but use a rubber sling around the muscle at various levels to retract it. Once the sternocleidomastoid muscle is retracted or divided, the omohyoid muscle shown in number 5 with its tendon overlying the internal jugular vein comes into view. We always divide the omohyoid to reach the internal jugular vein or the IJV. Try your best to preserve the IJV if uninvolved by the tumor, since division of the IJV leads to marked facial edema, which may be worse in patients who have already received radiotherapy previously. Retract the lowermost part of the IJV anteriorly and incise the thin membrane over the fat layer between the IJV and the trapezius muscle. This will help you to scoop the lowermost, that is level 4 nodes together with level 5 nodes. On the left side, be careful about the flimsy thoracic duct and avoid damaging it. Also try to preserve the supraclavicular nerves which traverses this fatty mass to enter the pectoral region by running superficial to the clavicle. Clearing the level 4 cervical nodes reveal the lower prevertebral musculature and the surrounding structures. You can see these structures in this slide. Number 1 shows the scalenus anterior muscle. Number 2, the scalenus medius muscle. Number 3 shows the phrenic nerve which runs deep to the fascia overlying the anterior scalenus muscle. And number 4 shows the transverse cervical vessels. Note, we have not shown the supraclavicular nerves in this slide. During this part of the dissection, avoid damaging the major lymphatic channels. If damage is inevitable, repair the damage or seal the channel. Carry out the nodal dissection upwards up to level 2. Retract the IJV all around to see nodes hiding between the IJV and the carotid artery. In this slide, number 1 shows the internal jugular vein, number 3 the carotid artery, and number 2 the vagus nerve which lies posterior in between the two vessels. During comprehensive nodal dissection, we always encounter 3 nerves. damage to any of these three nerves can lead to significant morbidity. These three nerves are the phrenic nerve, which we encounter during the lowermost part of the dissection, the accessory nerve, which we encounter during the dissection between the uppermost part of the sternocleidomastoid muscle and the IJV, and the hypoglossal nerve, which we encounter during the dissection around the carotid bifurcation. The accessory nerve passes in front of the uppermost part of the IJV in 65% of cases and behind the IJV in 35% of cases. It commonly pierces the sternomastoid muscle and runs along it in a S-shaped course or may even pass deep to the muscle. This slide shows the hypoglossal nerve. Iatrogenic injury to hypoglossal nerve is disastrous. Therefore, always carefully expose this nerve, which runs lateral to the external and internal carotid arteries about 1 cm above the carotid bifurcation. The final step is to perform level 1 dissection together with the submandibular gland. The facial vein running over the gland is divided and the fascia overlying the gland, which contains the marginal mandibular branch of the facial nerve, is swept off of the gland superiorly. The tendon of the digastric muscle is retracted inferiorly while maintaining upward traction on the gland to deliver the facial artery passing deep to the digastric muscle and the gland. The facial artery is then divided both at this level and also at the level of the lower border of the mandible, since there is a very good blood supply from the contralateral facial artery. The gland is finally delivered by dividing the duct and the submandibular ganglion attached to the lingual nerve. Rarely, in certain patients, simultaneous bilateral comprehensive cervical nodal dissection may be needed. In such cases, preserve IJV on both sides or at least on one side. Otherwise, the risk of having acute cerebral edema would be quite significant. If bilateral IJV sacrifice is essential, delay surgery on one side for a few weeks. With that, we come to the end of our presentation. Thank you for watching.